Hey everyone, Dr. Shahid here, and in this video we'll go over the various restorative materials we have at our disposal along with the proper techniques we need to implement to ensure a long-lasting restoration. We'll start with the most popular material in all of dentistry, composite resin. Composite resins come in various types, each designed with specific properties to meet different clinical needs. First, we have microfilled resins, which, as the name implies, have very small filler particles. These are primarily used for aesthetic restorations where high polishability and a natural tooth-like appearance are very important. The downside is that they're relatively weak, so they're typically reserved for low-stress areas such as Class 3 restorations. Next, we have hybrid resins, which combine both small and large filler particles, and because of that, these resins offer a balance between strength and aesthetics. So they're pretty versatile in that they can be used for both posterior and anterior restorations. We can also have nano-hybrid resins, which are kind of an evolution of hybrid composites. They incorporate both nano-sized fillers and larger particles. These nano-hybrids provide improved wear resistance and aesthetics compared to traditional hybrid resins, making them an excellent choice for most clinical situations, especially for posterior teeth given their superior strength. Lastly, we have nano-filled resins, which contain ultra-small filler particles, making them ideal for anterior restorations where aesthetics are critical. So you guys probably noticed the trend here. Smaller filler particles allow for superior polishability and aesthetics, while larger filler particles give rise to superior strength. Alright, and now that we've gone over the different types of composite resins, I want to quickly talk about how we can maximize the function and aesthetics of our restorations. And it all begins with proper contours and occlusal and proximal contacts. And the best way to achieve that is with the trusty sectional matrix. After you've prepared the tooth, in this case a first molar MOD prep, you place the matrix bands in the proximal regions, followed by the wedges, which help stabilize the bands against the natural tooth structure. Finally, you place the rings, which hold everything nice and tight. Alright, so what's the best way to restore teeth with composite resin? Well, first of all, sectional matrices do a wonderful job of mimicking the curvature of natural teeth. This is credited to the shape of the matrix bands and the overlying ring. Second, it ensures we have tight and broad proximal contacts, again, thanks to the shape of the matrix bands and the tension that's provided by the rings. Lastly, the wedges establish the all-important gingival seal, which is crucial for the longevity of any restoration. Alright, so now you're ready to fill the cavity with your composite. But you gotta be mindful to not just fill the entire cavity all at once. You'll want to carefully place your composite in increments of about 2 millimeters. And this is important for two main reasons. Incremental layering will not only minimize polymerization shrinkage of the resin, but it also respects the maximal depth of penetration of our curing lights. If you fill a deep cavity all at once, you'll end up with incomplete curing, which can lead to weak restorations and marginal leakage. Alright guys, let's now quickly talk about a few complications that our restorations can face. The first one is recurrent decay, which is actually the most common cause of failure for these restorations. Recurrent decay will typically present as darkening under the restoration or around the margins. The second complication is hyperocclusion. Patients will typically complain about this one within the first week or two of having the restoration placed, since it's likely to cause sensitivity due to the tooth taking on more than its fair share of the occlusal load. Alright, the last complication I want to talk about can't actually be seen from this angle. So let's turn our molar around so that we can talk about improper proximal contours. This is a complication that happens when we don't spend the time to make sure our matrix system is adequately placed. This can result in over-contoured or under-contoured restorations, which can then cause recession and sensitivity. Unfortunately, you'll have to redo the restoration in some cases, depending on the size of the defect. Okay, enough of composite resins. It's time to switch gears and talk about glass ionomer. Glass ionomers are a pretty versatile restorative material with unique properties, making them particularly effective for specific clinical scenarios. One of their key features is that they are hydrophilic in nature. This allows them to perform well in moist environments, such as subgingival areas. Another standout feature of GI is its ability to release fluoride. As you guys know, fluoride is crucial in the remineralization of enamel, offering a caries preventative effect. It also has the advantage of forming a chemical bond, both to enamel and dentin. And if that wasn't enough, glass ionomer is very biocompatible. And when you consider all of these beneficial features of glass ionomer, it's no surprise that it's an excellent choice for restoring class 5 and subgingival preparations where moisture control can be challenging. Its fluoride release also makes it a great choice for high caries risk patients. However, like I always say, every material has its downsides, and for glass ionomer, you'll want to ensure you use it in non-stress bearing areas because it just isn't as strong as resin composites. With that said, there is a technique you can use to take advantage of the best properties of glass ionomer and resin composite, and I'm hoping you guys know exactly what I'm talking about. It's none other than the sandwich technique, which is essentially a way for us to benefit from the moisture tolerant and fluoride releasing nature of glass ionomer while still maintaining superior strength and enamel bonding with resin composites. Now, this sandwich can come in two varieties, open or closed. But for the sake of simplicity, I'm going to show you guys the open sandwich technique here. It all begins with conditioning of the preparation with 20% polyacrylic acid. This is sometimes known as the cavity conditioner, and it's just the etchant that works best with conventional or resin-modified glass ionomer products. Next, we'll want to rinse off all of the acid just as we do with phosphoric acid. The steps are the same. And once the preparation is all clean, we can place our glass ionomer. Once that's cured, you'll want to etch the remaining enamel with phosphoric acid and place composite resin right over the GI. So in essence, the GI base offers fluoride release and adaptability in subgingival areas, while the composite provides durability, better enamel bonding, and a more natural appearance. Okay, I have one other restorative material that I want to talk about, and it's none other than amalgam. Dental amalgam is an equal mix of amalgam alloy and mercury. The alloy itself is composed of various elements, the primary one being silver. Up to 70% of amalgam can be silver, and it provides strength and corrosion resistance to the alloy. Tin is the next major element, comprising up to 30% of the alloy, and it helps in improving workability and reducing expansion of the restoration. Next we have copper, which makes up about 10% of the alloy, and just like silver, it also adds strength and corrosion resistance to the alloy. Finally, we have zinc, which is present in very small amounts and acts as a scavenger for oxygen, enhancing the longevity of the material. Now, unfortunately, amalgam sometimes gets a bad rep because of its mercury content, but all good science out there still shows us how good of a material it actually is. One thing we do need to keep in mind though, if we want to take advantage of all of amalgam's benefits, is that it does require a minimum thickness of 1.5 millimeters. This depth gives us adequate resistance to occlusal forces and ensures the material's integrity under functional loads. Finally, how we mix the amalgam alloy with the mercury is also very important. This is known as trituration. Proper trituration results in a shiny and smooth mixture. Over-trituration leads to a wet and overly soft amalgam that sets too quickly. And under-trituration produces a dry and crumbly mix that compromises the strength and stability of the restoration. And now it's time for an extremely unpopular and misunderstood topic, the phases of amalgam. And I'll try to clear it up for you guys using an analogy. Making dental amalgam, guys, is like baking a chocolate cake. You mix flour, eggs, sugar, cocoa, and butter, as we do with amalgam alloy and mercury, and during baking, new structures form. The cake rises and the ingredients begin to interact with each other in different ways. The final cake has different textures and layers, and dental amalgam is the exact same. So think of the phases of amalgam as just different layers we have in the final restoration once it's set. The first phase is the gamma phase, which is the strongest phase, and it's just made up of unreacted silver and tin. This layer provides the bulk of the strength to our restoration. The gamma 1 phase is what gives us our corrosion resistance, and this layer is made up of silver and mercury. And finally, we have the gamma 2 phase, which is the weakest phase, and it's made up of tin and mercury. This is the worst layer, guys. It's like having raisins in our chocolate cake. Nobody wants that. Thankfully, there's a way to eliminate this layer, and we can do so by simply increasing the copper content in our amalgam alloy. Now, the interesting thing about the gamma 2 phase is that it becomes more pronounced with time, especially in alloys that are not high in copper. which brings us to the next quick topic of amalgam corrosion. Corrosion is caused by the very same weak gamma 2 phase that we just talked about. So if you have a patient come in with an old amalgam restoration that's looking very dark and dull, it's likely an old amalgam alloy that was not high in copper, and therefore it underwent corrosion. Another sign of amalgam corrosion is staining, which results in a bluish discoloration of the surrounding enamel or dentin. And again guys, if you know your materials, for any new amalgam restorations that you do, just make sure they're high copper amalgam and you'll avoid all of these issues altogether. And with that guys, it's time to reinforce everything we just learned with a few practice problems. Question 1. A patient presents with a deep MO carious lesion on tooth number 30. What is the best treatment approach? Pause the video, make sure to read all the option choices and understand them, and the answer is D. You'll want to remove all infected dentin, leave the affected dentin, place a glass ionomer, and finally restore. So the key here is that removing only the infected dentin preserves tooth structure and avoids unnecessary pulp exposure. The glass ionomer then acts as a protective barrier and provides a stable base for the final composite restoration. Alright, moving on to question 2. We have a 31-year-old male with the following chief complaint. Food keeps getting trapped between my bottom left teeth. Background on our patient history reveals atrial fibrillation and hyperlipidemia, and the patient is currently taking atorvastatin, dabigatran, and metoprolol for medications. Current findings indicate open mesial and distal contacts on number 20 MOD restoration. We also have a periapical radiograph to go along with the information. So the question reads, what is the most likely cause of the open contacts seen in this restoration? As always, pause the video if you need some time, but the answer would be C, poor contour and adaptation of the sectional matrix. Remember guys, proper matrix placement is crucial to ensure a tight, natural contact and prevent issues like food traps and gingival irritation. As for the other option choices, marginal ridges really have nothing to do with our proximal contacts, and option choice B and D would actually help us get tighter contacts, not weaker ones. Alright, let's move on to the third question. What is the most likely cause of the fracture observed on the amalgam restoration? As always, pause the video if you need some time, make sure to check out the radiograph, and the answer is A. Remember guys, amalgam requires a minimum thickness of 1.5 millimeters to withstand occlusal forces. A shallow preparation fails to provide the necessary bulk, which can lead to structural weakness and eventual failure under functional loads. As for the other option choices, high copper amalgams are actually stronger, over-polishing of the restoration isn't a thing, that wouldn't make it weaker, and amalgam is actually a pretty moisture-tolerant restoration, so that can't be it either. Alright guys, with that we are done. As always, here's a quick list of high yield points that I went over in this video. Thanks for watching and see you next time.